to this presentation on respiratory therapy, a high-tech, high-touch profession. My name is Claire Alone, and I am the Program Director for the Respiratory Therapy Program in the College of Health Professions at SUNY Upstate Medical University. This slide shows a number of links to a place called beanrt.org, which has a whole lot of really good information on all different aspects of the respiratory therapy profession. It's from our national professional organization. I would encourage you to go to beanrt.org if you want more information. One of the things we talk about with respiratory therapy is we call it a life and breath career. Respiratory therapists are health professionals. We're responsible for taking care of patients who have a variety of different heart and lung problems. We care for patients of all ages, from newborn infants to the elderly and everyone in between. The career opportunities are excellent. Our salaries are competitive with other health professions. Our goal is always to apply scientific principles to help prevent and identify and treat acute or chronic dysfunctions that affect the cardiopulmonary system. And we are experts who specialize in health promotion and disease prevention to help patients have optimum cardiopulmonary function and health. So what are some of the desirable characteristics that make a great respiratory therapist? Well, you really have to like working with people. We work all day, every day with patients, families, and other members of the healthcare team, most particularly physicians and nurses. We work side by side with them pretty much every day. You have to be flexible and energetic. We spend a lot of time moving around in whichever position we occupy. And we have to be very flexible because things change moment to moment sometimes with our patients. You have to like challenges, and you have to like using critical thinking. You're often relied upon to use your critical thinking skills to figure out what's going on with the patient. You have to be comfortable with technology, which for the current generation doesn't seem to be much of a problem. Much of the stuff that we do and the equipment that we operate is very technical. You have to be self-confident, empathetic, and have integrity. And I think those are all good things to have, regardless of whether you're a respiratory therapist or another profession. And you really have to want to be a lifelong learner. That's true of medicine in general. Things change on almost a daily basis, and you have to be interested in continuing the learning process. The respiratory therapists work in a lot of different settings. Our National Professional Association does a survey every 4 or 5 years, and in the last survey, approximately 75% of the therapists were working in acute care hospitals. And that's the most common place we work. Within the acute care hospital, we may work in a lot of different settings, and we'll talk about those. But we also have therapists who work in diagnostic laboratories, rehabilitation, skilled nursing facilities, patients' homes, doing emergency transport, working in a physician office, working at a college or university like I do. Sleep centers are generally staffed by respiratory therapists. Some therapists work in research facilities, and also therapists may work in industry. Another thing that we often get asked is, what kind of patients do you take care of? Well, we very often spend a lot of our time taking care of critically ill patients who are in intensive care units, on ventilators, and other forms of life support. That could include accident victims, especially if they have trauma to their head and their chest. We also take care of premature infants. We attend high-risk deliveries. We take care of both adults and children who have different acute and chronic lung diseases. That might include asthma, COPD, cystic fibrosis. We often care for patients with sleep disorders. Many of our patients have heart disorders. and also neuromuscular patients whose lungs may be fine, but the nerves and muscles that keep us breathing are not working so well. Respiratory therapy is often referred to as the high-tech, high-touch profession. This is a picture of high-tech where you can see therapists involved in a lot of different technical activities, whether it's operating a ventilator, putting a tube down someone's airway so that we can help them breathe, assisting with cardiopulmonary resuscitation, or many other things. Well, this is a very long list of some of the different things that respiratory therapists do, everything from resuscitation to working in outpatient clinics. And I'm going to go through a few of these with you so you have a little bit better idea of what the respiratory therapy profession is all about. One of the things respiratory therapists are pretty universally involved in is resuscitation. So within the hospital setting, we often are the in-house first responders, and we actually have first responder status with that organization. When something is going down that's not going well, respiratory therapists are generally called to the scene. Adult resuscitation, you can see on the left here, we have a therapist, and generally speaking, we're responsible for managing the airway and making sure that it's in place. If there's no airway in place, that we maintain an airway, and that we provide for breathing for the patient. So if you're familiar with the ABCs of resuscitation, we're responsible generally for the A and the B, the airway and breathing. Compressions or the cardiac portion, we often assist with those. Generally with resuscitation, we like to rotate people who are doing compressions really frequently because it's pretty easy to get tired and not do them as well as you could. But we're always responsible for the A and the B part. And we do that for adults. We also do that for newborns, and that's a little more challenging because their lungs are really tiny. So we have to be really careful that we don't put too much air into their lungs. And this picture shows a new machine that we've been using over the last several years, which really helps us to control the amount of air that we push into the baby's lungs. It makes it very easy for people who don't do this very often to do it really well, because it is something that requires some skill. As I mentioned, we're often responsible for the airway. Many respiratory therapists are able to establish the airway. We call that intubation, where they actually put a scope inside the patient's mouth and look down the throat and put a tube down and make sure it goes into the right place, because of course you have the opening to both the stomach and the lungs in the back of your throat. You definitely want it in the one that goes to the lungs. And we're also responsible generally for maintaining the airway, and that could include suctioning. That's a very common practice that's shared by nurses and respiratory therapists usually. And also making sure that the tube is secure, that it's in the right place, that it gets moved a little bit so it doesn't cause pressure sores on the patient's lips. So all those different things related to airway maintenance. As I mentioned before, many of us spend a lot of time working in intensive care units, and we're involved with life support, which is another name for mechanical ventilation. Mechanical ventilation can be divided into invasive and non-invasive categories. Invasive basically means that there's a tube down into the patient's lungs, either through their nose or mouth or directly into the trachea through a tracheostomy. That's invasive ventilation. Non-invasive ventilation is where we apply kind of the same techniques, but we do it with a mask on the patient's face. And that has become a huge part of what we do. It's always nice if you can get away with that so you don't have to put the tube in, because the tube is uncomfortable, the patient can't talk. And so we try to do non-invasive as much as we can, and we've done lots and lots more of it over the last several years. Well, much of our time is spent with adult patients who need to be ventilated. We also ventilate newborns and children. of all ages. So on the left, you'll see a picture of a little girl who is on a ventilator. She has a tracheostomy tube in place. And this is a home ventilator, a portable ventilator, so that persons who have to be on a ventilator outside of the hospital, whether they're children or adults, can be mobile as much as possible. So with kids, we like them to be able to go out, go to daycare, go to school, those kinds of things. So the home ventilation is a huge part of what we do, not just for children, also for adults. And then in infants, we often have some very specialized things. While we do regular mechanical ventilation, both invasively and non-invasively with newborns, we also have a special technique called high-frequency ventilation, which kind of vibrates the lungs and causes some gas movement in without damaging the lungs. Because with newborns, actually with all patients, we're always worried about, can that pressure we're putting in the lungs, can that damage the lungs? And we kind of have to balance between keeping the patient doing well and alive, but not damaging the lungs in the process. Another thing that we sometimes do for life support is something called extracorporeal life support. We often refer to it as ECMO, extracorporeal membrane oxygenation. And that's pretty much because the machine that we use is called a membrane oxygenator. So therefore ECMO. This can be done for both infants and children and adults. The infant world, we've been doing ECMO for a very long time for babies that are born prematurely or babies that have very severe lung disease. And what we do basically is we divert the blood out of the body through a machine that puts oxygen into the blood, takes carbon dioxide out of the blood, and then we put the blood back into the body. And we do this because the lungs simply aren't capable of doing it on their own. We've been doing it for babies for a very long time. We do less of it in babies now because we've gotten better at doing things that don't involve taking the blood out. This is basically the same procedure that's done in the operating room when you have open heart surgery, where they bypass your heart so they can operate on it. And in adults, we have not done it as much, but recently we've discovered that it can work very well to extend the life of adults who can get better. We just need some more time than we have right now. And so we're seeing a lot of ECMO being initiated in adult patients in various intensive care units. And locally in Syracuse, we have ECMO units at all three major hospitals, University Hospital, at Upstate, Krause Hospital, and St. Joe's Hospital. Another thing that respiratory therapists are involved in is transport, both air and ground. And many therapists do this as their sole job. That's what they do every day, is they transport patients. In some cases, it's part of your job. So you may be on the transport team and you may be called one day to do a transport, but on another day you may be working in the intensive care unit. So we do transport very sick patients, usually babies and children who have to be transported into a center that provides care for them, because every hospital is not capable of taking care of very sick infants and children. Another thing we do is something called blood gases. The gases in your blood that we're mostly concerned about are oxygen and carbon dioxide. And then we also try to look at the pH, how acid is the blood. And those things can really tell us a lot about what's going on with our patients. So we are generally involved in sampling arterial blood, a little different than what you might be used to when you have to give blood at the doctor's office for a blood test, because that comes out of veins and we're looking for arteries and they're kind of hidden. So we have to find them and aim for them. And respiratory therapists get very good at that. It's something that we do a lot of. We also often analyze the blood. So the blood goes into a special machine which checks the level of oxygen, the level of carbon dioxide, the levels of some other things in the blood, and the pH. Sometimes we do that directly at the bedside. We now have what we call point of care testing, where we carry a little piece of equipment with us, and we can analyze the blood right there at the bedside, or we may have an external laboratory style blood analyzer. And in some institutions, the analysis is done by the lab rather than by the respiratory therapy department. We also do a lot of monitoring. Probably the most common is oxygen monitoring with what we call pulsed oximetry. And you may have seen these little things that fit on the end of your finger. They measure your pulse rate and how much oxygen is in your blood, what percentage of your blood is carrying oxygen. And that can be done as kind of a one-time check, but it can also be done continuously. It can be done overnight. We can analyze the waveforms that come out. So it can be a very simple test or a very sophisticated test. The other thing we often do is carbon dioxide monitoring, where we measure how much carbon dioxide is coming out in the exhaled gas that a person breathes out. And that allows us to tell pretty much how the lungs are functioning. Both of these things, oxygen and CO2 monitoring, are non-invasive ways of assessing what's going on in the blood. And so they may help us to not have to draw blood as often. Another thing respiratory therapists are often involved in is sleep testing. So if a patient is not having good sleep and the physician wants to know what's going on while they're sleeping, they'll refer them to a sleep lab, where they'll be hooked up to all kinds of different monitors during the night. On the left, you can see our therapist is starting to get our patient hooked up. Those things on his head are for hooking up an electroencephalogram so we can measure brain waves. And on the right, we have the therapist and physician looking at the monitor, which records all of those things. And from that recording, we can tell what kind of sleep disorder the patient might have, and then maybe what best therapy would be for them. One of the things that we often find when patients go for sleep testing is that they have sleep apnea, which means that they stop breathing, either completely stop breathing or their airway closes off. So while they're trying to breathe, they're not getting any air into their lungs. And that's called sleep apnea. And one of the things we do for that is something called CPAP, or continuous positive airway pressure. So we, as part of our job, we often fit patients with, we don't even call them masks anymore, we call them interfaces, because many of them are not really masks. They have all different kinds of configurations. And we put that over the patient's nose or mouth or into the patient's nose, and then titrate it to see how much pressure do they need to help treat their sleep apnea. One of the things that we are very involved in is oxygen therapy. Gas therapy is generally the responsibility of the respiratory therapist. Oxygen is the most common gas we administer, but it's certainly not the only one. In the hospital, generally, if a patient requires a low level of oxygen, that's usually a nursing procedure. But as they get sicker and they require more complicated oxygen delivery devices, the respiratory therapists usually take over. In the home, that's the most common thing we do in the home, is deliver oxygen therapy to patients who don't have enough oxygen in their blood. Medication administration is a huge part of what we do. Many of our patients use inhalers, and we teach them how to use them appropriately, hopefully with a spacer, which allows much better deposition of the drug into the lungs where it needs to be. Many drugs are now available in dry powders, and so the inhaler basically helps us to suspend that dry powder in the air so the patient can breathe it in. And there are so many different types of dry powder inhalers and other types of inhalers that it's difficult sometimes for patients to keep up with them. Probably the simplest way to administer a medication is with a nebulizer, and that can be done with either a mouthpiece or a mask. We always prefer the mouthpiece because you get a lot more deposition into your lungs with a mouthpiece than with a mask. And you can administer lots of different medications this way. So we do these a lot. Also, they tend to be very inexpensive. So for some of our patients, this is the best option because it's what they can afford. Another thing respiratory therapists are very skilled in is lung clearance, where people have something in their lungs that is they're not moving, and that's a great place for infection. So when we have a patient who can't clear their lungs adequately on their own, we help them. The probably best example of this is patients with cystic fibrosis. And most of the devices that were developed for lung clearance were developed with cystic fibrosis patients because they have very thick, sticky secretions that clog up their lungs, and removing them is a huge part of their therapy. So there are lots of different ways we can do that. Here we have a patient on the left doing something called OPEP, oscillating positive pressure, where they breathe out through a device that vibrates, and those vibrations or oscillations go back into their lung tissue. We can also do that as a high frequency oscillator through a machine that provides similar types of vibrations. And the original lung clearance therapy was basically chest physical therapy, where we would actually cup our hands and then clap over the different areas of the lung to loosen the secretions. And we could also provide vibration with our hands so that we could vibrate the secretions loose. This is a great therapy. The problem with it, of course, is that you can't do it on your own. You need someone to do it for you. It takes a very long time to do it in all different positions, to drain all different areas of the lung. And it is extremely difficult for some patients to get into all those different positions. So that's one of the reasons why so many other devices were developed. And probably the one we think about the most is the one on the right, which is called the VEST. Chest vest is actually name is high frequency chest wall oscillation. So this is the same idea as the OPEP and the high frequency oscillator that we showed in the previous slide, except this vibration comes from the outside of the chest instead of through the mouth and into the lungs. That way, it actually vibrates the chest wall, which is then transmitted into the airways. And that works really, really well. Most of our cystic fibrosis patients use this pretty much as their mainstay for their therapy. So another thing that we do is respiratory assessment. We do that pretty much all the time. It can be very simple. It can be a bedside assessment where we're listening to the lungs and looking at different signs and symptoms that the patient might have, or maybe percussing the chest to see if there's some fluid in there or some pneumonia. Or it can be more sophisticated where we do various types of pulmonary function testing, sometimes at the bedside and often in a very fancy high-tech laboratory. We do a lot of patient education, and this is becoming increasingly important as we're trying to help patients with, particularly with chronic diseases, manage themselves so that they don't need to come back into the hospital or the emergency room. So we do teaching at the bedside in the hospital, where we teach patients about their disease process, their medications, how to appropriately take all their respiratory medications, what symptoms to watch out for at home to tell if they're getting in trouble, those kinds of things. And we also do that in the home, where we may teach the same types of things, but also how to use the different types of home equipment. Another thing we do is pulmonary rehabilitation, and that's where we take patients who have chronic diseases and help them to improve their quality of life by learning about their disease process, but also by exercising. And that's been shown to be very, very good at helping patients stay out of the hospital, be more active. Pulmonary rehabilitation programs are very rewarding for both the therapist and the patient. It's really neat to see your patient go from not being able to get out of their chair to being able to go out and do some of the things that they really want to do. A number of respiratory therapists work in home care. We can do almost everything in the home that we can do in the hospital. So we can provide medical gas therapy, mostly oxygen. We can provide mechanical ventilation in the home. We can provide sleep therapy. Lots of different things that we can do in the hospital, we can also do at home. And many respiratory therapists work in that setting. The other part that we want to remember about respiratory therapy is, well, it is a very high-tech profession. It's also a high-touch profession. We spend a lot of time at the bedside with patients, with families, and we're doing a lot of hands-on care. This is a 24/7 profession. We are there around the clock in the hospital. And we also do a lot of things that we've talked about with rehabilitation and home care and patient education and those kinds of things, which are much more on the high touch end of the spectrum. But respiratory therapy kind of nicely combines the technical part with the patient care part. So I know that was a lot of information. So kind of a summary, what do respiratory therapists actually do? We evaluate, we treat, we educate, and we care for people with lung and heart disorders. And I probably should add, of all ages. Of course, one of the things we always want to know is what does the job market look like? And it is awesome. We are one of the fastest growing professions according to the U.S. Bureau of Labor Statistics. Great increase in demand for respiratory therapists over the next 10 years. The New York State Department of Labor Statistics predicts pretty much the same thing within New York State. So lots of growth. So why is this need for RTs growing? Well, there are lots of different factors. We have a large increase in the elderly population in our country. And of course, the older you get, the more likely you are to have something happen. The environmental impact on diseases, we've come a long way with some things, but we still have a lot of patients who have a huge environmental impact on their asthma. Smoking, again, we've come a long way with smoking, and we've dropped our smoking rates greatly, but there's still pockets of people who have very high rates of smoking. We have technological advances in the treatment of our disease, so we're keeping people alive longer, which means we need more therapists to take care of them. That's particularly been true as we've advanced our techniques for mechanical ventilation and ECMO. And then we have some excellent advances in the treatment of premature babies. So again, we're saving babies that are more and more premature. And salaries are pretty good. They do obviously vary with educational degree and years of experience. And as you become a supervisor or a clinical specialist or a department manager, salaries tend to go up. Salaries are higher on average with BS degrees. That might not be true when you first get hired out of school. Some hospitals do hire at a different rate and some don't. But if you look at over the course of a career, people with bachelor's degrees definitely have higher salaries than those who do not have bachelor's degrees. We have some salary figures here, and of course these always lag behind. It takes a couple of years to get the salary data updated, but median starting base salary between 45 and 58, and that has gone up considerably over the last couple of years. Median salary in New York State between 56 and 74, and present median experienced therapist salary between 64 and 82 in New York State. So what about respiratory therapy at SUNY Upstate? Well, it's a Bachelor of Science degree. That's really important because our profession is advancing to a bachelor's entry level. That process is ongoing over the next several years. So it's really good to be able to enter the field with a bachelor's degree. We have a lot of opportunities for leadership in our field if you have a minimum of bachelor's degree. We are pretty good at what we do. We've been doing it for a long time. We graduated our 50th class in 2019. We have 100% pass rate on our board exams, 100% job placement, and a very high retention rate. We offer on-campus programs as well as are developing some distance learning programs. Our faculty are outstanding and they're very accessible. And we do allow people to specialize in their area of interest in their final semester. So some other great things about Upstate and why you might want to be a part of our program. We are an Apex Award winner for the 2019-2020 time period that recognized us for achieving the highest level for academic programs in respiratory care. There were 16 award winners nationwide that included hospitals, schools, and some other organizations that employ respiratory therapists. And there were only 3 educational programs recognized, and we were one of the 3. So we're very proud of that. We have very small class sizes, so you get to know your fellow students and your instructors really well. A lot of interprofessional education opportunities because we are a medical university, so we have lots of other medical professions to interact with. And we have really outstanding clinical affiliation partners who work very closely with us and do a great job helping to educate our students. So preparing for our program, you have to complete 53 credits, and there are some required courses. Mostly we're looking for a very strong foundation in math and science, which is pretty typical of most medical professional programs. This is a list of our prerequisites. You can see that we do require anatomy and physiology at least 1 semester. Our preference is 2 semesters of anatomy and physiology, and then 1 semester of microbiology, all with labs. We will accept some substitute biology courses for people who've already taken a lot of biology courses. And we also require chemistry, math, English, and psych or soc, and then whatever liberal arts electives you choose to take. We do open our applications on September 1st for the following fall. We do early assurance for high school students. We also have regular admission processes. We do a rolling admission, so we keep admitting people until our class is full. It does require both a SUNY app and a supplemental app, your transcripts, and 2 letters of recommendation. We love having them from people who have had you in class, but we do accept also from employers. After the application is received, we do a holistic review. We're looking for a 3.0 as our admitting GPA, but we do also know that sometimes people have things happen, and we're open to allowing applicants to explain those things to us. And then, of course, our letters of recommendation, personal statements, experience and knowledge about the profession. We often like people to go and shadow in the hospital so that they can learn a little bit more about our profession. We do an on-site interview, and then our admissions committee makes a decision. The curriculum is very heavily oriented towards respiratory therapy courses. We do have 2 gen ed courses. One is ethics, and the other is a English technical writing course. We have 1 science course in pharmacology, and the rest are respiratory therapy courses, divided fairly equally between theory and core courses, in other words, classroom style courses, and laboratory and clinical courses. We are working on offering a distance learning program in Binghamton. We have a clinical campus in Binghamton that would involve the gen ed courses. Both English and ethics are online courses. Pharmacology can be an online course. We have respiratory care core courses. The junior year courses would be taught in Binghamton with a classroom connected to the Syracuse classroom. So distance learning labs would be offered in Binghamton. And in the senior year, some of the courses are online and some courses are blended, meaning that you have to come to Syracuse a couple of times during the course. Clinicals would primarily be in Binghamton, except for pediatrics and ECMO training days, and maybe a couple of other things that just aren't offered in Binghamton. Anything that's offered in Binghamton, we would do there. Next, our admissions office, Wendy will do a nice pre-advising for you if you like, and look at where you're at and what you still need to do. We do recommend shadowing, and we will be able to set that up for you. We'd like to do that. If you have any questions, we're always happy to help. You can visit our website and look at our respiratory program information there. So in conclusion, respiratory therapists make a huge difference. I borrowed this from the American Lung Association. It's one of my favorite sayings. When you can't breathe, nothing else matters. How true is that? If you can't breathe, you really can't do anything else. And we are so rewarded by being able to help people to breathe better. If you need more information, our admissions department would be very, very happy to help you and put you in touch with whoever you need to be in touch with. And we thank you very much for listening and look forward to talking to you.